Yeah, ma'am.
Should I start talking in that case?
Yes, ma'am.
Okay, this is a 7-month-old child. He is posted for bilateral CTEV and his weight is 8 kilograms. He is currently lost under the drapes, but I shall explain you the block that I need to give and what are the anatomical landmarks. The first, first I was told that this is a CTV case, so I was quite happy because it would be a unilateral case and then it would be a sciatic block. But now since it's a bilateral case, the appropriate block is a caudal block, so the fun is a little less now because it's a very commonly given block. Hence we've come back to the central neuroaxis. Now I've placed the child in lateral position and I have marked the anatomy for you. These are the two posterior superior iliac spines and I'm just dropping my finger to do the sacral cornus. So this is the cornu that I'm feeling and these are the vertebrae. Alright. So what I have planned to do is I'll just stimulate the sacral, the phylum terminal as such, and then I would trace it with ultrasound and show you the drug spread along the posterior dura, which could be taken as a surrogate marker for a proper placement of epidural, and another way of assessing the level at which the drug has gone and hoisted itself. Can I proceed? Am I clear?
Yes, ma'am. It's clear, ma'am.
Can you start the? Can you start it?
Yes, ma'am. Yes, ma'am.
Can you? You can start the nerve stimulator and the current should be around 3. 3. These are nerve roots, so they need a higher current to get stimulated. A little more of adjustments. Can you see the perianal twitching? Is this evident to everybody in the auditorium?
No, it's not visible, ma'am.
Okay, you need to focus from here. Excuse me, if the camera is too close to me, I feel there is somebody breathing down my neck. So, could you please show them this?
You need to show
the perianal twitching that is happening here. Let's increase it to 4. Yeah, maybe now it's a little stronger to appreciate. Can you now appreciate in the auditorium?
No, ma'am.
Here?
Yes, yes, yes.
You're saying, okay, maybe the anal winking is what I want you to appreciate. Maybe the light has to be focused right on it. Okay, now is it appreciable?
Yes, yes, now it's visible. Yes.
Okay, fine. So this is the proper placement. Now that, yes, please off it. We will trace this needle with ultrasound too. Can you get me some jelly? I have just attached a bit of Tegaderm here and a sterile jelly. Usually in day-to-day practice, if the sterile jelly is not available or somebody keeps raising an eyebrow every time you ask for sterile jelly, we could even use normal saline or betadine. The problem with it is that it dries up a little too fast, but then that's all right. Can you appreciate the needle here?
Yeah.
Yeah. Before going to the needle placement as such, let me just orient you to the sonoanatomy itself. Please visualize where the probe is. The probe is placed on the sacral cornu transversely. So the scan seen now is a transverse section at the level of the sacral cornu. I'm going to read the section out for you now, and maybe Mohan will try and put the arrows there. From the posterior, that's the posterior of the patient, and that's the anterior of the patient. Yes. Now, from the posterior, let's start with the skin and subcutaneous tissue. This is the skin and the subcutaneous tissue up there. Now, can you please see this? The arrow is being pointed out to one of the sacral cornus. The pair of the sacral cornu is lying right here. Okay. Now there is a sacrococcygeal ligament right in between them. That's the sacrococcygeal ligament. Okay. And this is the base of the sacrum. And this is the caudal space out here. Now this is the transverse scan. Since we need to appreciate the drug spread, I'm going to keep the probe now longitudinal. Now the needle is already in place, and I'm going to read the anatomy for you. These are the sacral spines. So that forms the roof. This is the base of the sacrum. That's the floor. Since I'm not getting a feedback from you, I don't quite know whether it's quite clear.
It's quite clear.
Thank you.
You can carry on, vrushali.
Yeah. Thanks, Guru. Now this is the needle right in between the two. And I'm going to now inject the needle. Can you see the flow?
Yes.
Yeah. Now, what is more interesting to observe is go a little more proximal. Visualize the posterior dura. You can take the arrow down until we see what we want to see. Yeah. Can you increase the gain in the far region, and can you increase the depth for me? Yeah. That's great. Fine. Thank you. Now you are seeing the entire neural conduit in front of you. From the posterior to the anterior, you're going to see the skin and subcutaneous tissue, and then one spine, and then another spine, and then there is a gap in between the two spines. Can you show the middle one? That's very clear. Yes, the gap. And then can you see this structure which is white hyperechoic line, and that's the posterior dura. Okay. So having having kept my hand steady, I am now injecting the drug. And I guess the drug has not reached till there, so let me go a little more. Can I get some normal saline? I had taken around 3 cc's. We go back to the sonoanatomy now. Yes, can you show them the difference in the dural? This is the dura here. Get it closer to me so that I can point it out to you, Mohan. Yeah, this is the dura here, and that's the dura there. Okay? So can you see the difference? Now the anterior and the posterior dura have kind of come together. Yeah. I will go ahead. Can decrease the gain a bit, maybe they'll appreciate it better. Yeah. Can you see the two dura now, the posterior one and the anterior one?
Both are clear.
Yes, now see what happens to them. Yeah, you saw the drug spread now, almost till here it moved. So that's the magic. This is how you can understand at till what level your drug has really spread up. This helps especially in blocks like hernia where you need a level almost till L1 or even T12. You gave a caudal with a dose of 0.5 and the surgeon nicks it and you get an increase in heart rate or the child does move. Or at times I have even taken a dose of 1 ml per kilogram and have not yet gotten a good level. So this has helped to success to extract the maximum out of the given block.
can you put the probe back onto the sacrum and show how you say that the structure is a bone, different echogenicities?
Guru, I haven't understood your question. Could you please repeat?
You say it's one is a bone, other is a dura and all. How do you differentiate?
Okay, how do I differentiate? Fine.
Why you say it's a bone, whether there is a shadow or something?
Yes, okay. Yes, I will. Okay, Guru, yes, your question is now getting answered. Hopefully so. Well, can you form the posterior again? Mohan, take them to the posterior aspect. Yes, that's a posterior aspect. Now you see hyperechoic lines.
Right.
Now you come down a bit more anterior. You will see a dome-shaped structure which is white and nothing underneath.
Yeah.
Yeah, so that's supposed to be a bone, not that is a bone, which is a spine actually. Okay.
So the dark thing is a shadow?
Yes, shadow, the acoustic shadow imparted by the bone.
Okay.
And in between the two bones, there is a window which allows the ultrasound beam to go in, and then you see the posterior dura and the ligamentum complex.
Yeah, right.
And then later on, this is the glial tissue in between, come down. Okay. Yes, and that's the anterior dura. And even below down is the vertebral.
Okay, it's clear.
Body. If you want to see the same thing in the transverse section, this is how it would be seen. You can decrease the low far gain. In fact, even while you are giving the drug, this can be visualized.
Okay. Dr. Joshi wants to see the entire spread of the fluid now.
The entire spread of the fluid, yes, you could appreciate, but now that there is no positive force that is driving the fluid up,
Okay.
it would be difficult to appreciate.
Okay, thank you.
Yeah?
Yeah.
All right. Now that the block that I had contemplated for this kid, which was a sciatic block, I can't give it because it's a bilateral case, but I can read out the sonoanatomy for you. And purpose why I am doing this is just to make the audience realize how easy it is to read sonoanatomy of sciatic nerve block in such a small baby. And
no, she has already pulled out the needle.
Yeah?
1 minute, there's a question.
Yes. Please tell me. No, I can't hear the question.
Ma'am, you.
They're trying to get the person asking the question. to come to
Vrushali,
the
can you
mic.
hear me?
Yes.
No, ma'am.
Yes, I can hear you.
See, when you were visualizing epidural space,
Yes, madam.
could you feel the tip of the needle when you kept it horizontal? The transducer kept horizontal. Could
Yes.
you locate the tip of the needle? I'm not talking about when you keep it longitudinal, in plane.
Longitudinal is in plane, right?
Yeah, that I could see the whole length of the needle.
Yes.
But when you kept it horizontal and when I want to inject the drug, to localize how you did
that
it.
is Kudkal, madam, isn't it?
Yes.
Yes, madam, if I have understood your question right, you want me to tell you that whether I saw the tip while the drug was getting injected?
Yeah, when you kept it
Okay.
horizontal.
Okay, when I kept it horizontal and I was showing you the posterior dural sac, whether I saw the tip is that your question?
Yes.
Okay, I was far away from the needle. The needle is around 5 centimeters. Out of that, 2 centimeters was inside the child's body, and I had kept my probe at a level of L1 and L2 to see the posterior dural sac because of the drug that I have injected in the sacral cornu.
Okay.
Okay, so hence I did not see the needle, but I saw the drug passed through the needle.
Okay. While localizing?
While localizing, yes, I had seen the tip of the needle.
Okay.
Yes.
Madam wants
Okay.
to know whether in out of plane, did you see the tip of the needle?
Out of plane, no, I did not see the tip of the needle when it was out of plane.
Oh, that's what I want to know. You can't see.
No, you can see, but right now I think I did not do an emphatic
all right. Okay,
attempt to, because I was going to flip that probe over and see it in the longitudinal section.
Okay.
Yes.
Okay, thank you, Vrushali.
Thank you.
Ma'am, to confirm,
So,
confirm
I'll-
the needle position, Vrushali madam changed from the vertical one to the longitudinal one, so that you can see the entire length of the needle and
Yes.
by the injection.
Yes. Now I just want you to have a quick look at the sciatic nerve here. I have kept the probe this way. This way is very easy for me to say because now you can see what I am doing. The child is lateral, and if this was the unilateral case, I would have blocked the sciatic nerve of this particular leg. Simply keep the probe with the orientation marker towards the ceiling, and you see the sciatic nerve. If you read this anatomy well, sonoanatomy, it doesn't take much to locate the sciatic nerve by itself. That's the skin and subcutaneous tissue, the posterior of the thigh, that's the anterior of the thigh. This is the upper side, the ceiling. This is from where the needle would enter. That's the biceps femoris. This is the sciatic nerve. That's the femur here. Yes, so sciatic nerve block is as simple as this. It's hardly around, how many centimeters? Hardly 2 centimeters. Not even 2. It's 1.28 centimeters precisely. That's the depth at which sciatic can be blocked in such a small child.
Vrushali,
Yes.
can you show us the longitudinal pattern as well of the sciatic? This is John.
Yes. Yeah, hi John. Here.
Some of the audience are keen to know if you could inject some local around, just
Some
even,
local?
or even
I
saline.
don't know whether that would be a good idea because the child, we've already given a block in
Even
the...
normal saline is fine. She said.
That would be an unnecessarily prick for a child. And I can see butts are also nodding to what I say. So,
Okay, we'll talk about that
personally, if it was a unilateral block, I would have had more fun doing that. Yeah, this is the sciatic nerve and its longitudinal section lying right next to you. Not next to you, in front of you. Okay?
Yeah, thanks, Vrushali.
Yeah.
Vrushali, I think we'll move on to